Good evening. I'm Kathy Antela, Vice President of Education at the Immune Deficiency Foundation, and would like to welcome you to tonight's forum, Antibody Deficiency. What does it mean? This forum is being recorded. The recording will be available on the IDF website within the upcoming week. After the forum, everybody will receive an email with a link to a short survey about tonight's program. The survey will also include an opportunity for you to tell us what you would like to hear about at a future forum. So thank you in advance for taking a couple minutes to complete that survey. As always, a quick disclaimer. Please remember that the information presented during this event is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Please always seek the advice of a physician or other qualified healthcare provider with questions concerning a medical condition, and never disregard professional medical advice or delay seeking treatment based on information presented during this event. For over 40 years, the Immune Deficiency Foundation has served as the trusted organization for the primary immunodeficiency community, with the mission of improving the diagnosis, treatment, and quality of life of people affected by primary immunodeficiency through fostering a community empowered by advocacy, education, and research. As a result of our mission, IDF seeks to ensure that everyone in the United States affected by PI has a fully informed understanding of the PI diagnosis that affects them, all available treatment options, the expected standard of care, and all their opportunities for connection and support within the PI community. Whether you're an individual with PI, a family member, friend, or a healthcare provider, IDF is here to help. When you have questions about living with PI, health insurance, or more, simply go to the IDF website, click on Ask IDF, submit your question, and a staff member will be happy to follow up with you. Are you looking for support? If so, one option is to attend a virtual IDF Get Connected group. These groups are exclusively for individuals with PI and family members. They are led by our amazing Get Connected leaders who are volunteers, and they are scheduled nationwide throughout the year. And they are a great way to meet others and receive support in a small group setting. Another option, if you prefer one-to-one support, send a request for peer support via Ask IDF, and you will be networked with one of our wonderful peer support volunteers. Coming soon to your home, the next forum. Well, actually, September 20th, we are excited to have a virtual young adult hangout for young adults ages 18 to 25 diagnosed with PI. That will be, it's up on the calendar, and it will happen in the evening that day. Then on September 28th, we have a lunch and learn, and that will be midday. And then October 20th is the next forum, and that will be about paying for IG replacement therapy. Well, last weekend, we had an IDF education meeting in person in Kansas City. It was great. We had great presenters, learned a lot. It was great to see our sponsors. It was great to see those of you that attended. And we are looking forward to our next in-person IDF education meeting on October 22nd in Minneapolis, Bloomington, Minnesota. And then we will have one more this year on December 3rd in the Baltimore area, in Hanover, Maryland. So if you live in those areas, we hope to see you there. And of course, we are so excited about this year's PI conference. It will be a hybrid event, and it's held on October 6th through 8th. Virtual education and networking sessions will be offered throughout the conference. However, the final day of the conference will include the opportunity to meet in person in 3 locations, California, Illinois, and Maryland, and not only visit with our sponsors, visit with each other, watch the presentations virtually, but also to take part in the Walk for PI. So whether you join us virtually, in person, or both, we can't wait to see you. And information is available on the IDF website. IDF forums are made possible by our wonderful sponsors. It is due to their partnerships and contributions that we are able to provide programs such as this one to everyone in the PI community. So please join me in thanking our 2022 sponsors: CSL Behring, Grifols, Takeda, Horizon Therapeutics, Accredo, Octapharma, Farming Healthcare, ADMA Biologics, AstraZeneca, Bioproducts Laboratory, Kedrion Biopharma, Enzavant, X4 Pharmaceuticals, and Chiesi Global Rare Diseases. And during tonight's program, we have a few short videos from our sponsors.
For more than 100 years, we've turned innovative thinking into solutions. CSL's investment in innovation has helped to develop a robust pipeline of safe and effective medicines and improve existing ones so that we can bring patients meaningful innovations and advancements that make their lives better.
My name is Dana Fladhammer. At Takeda, I am the Director of IG Community Support. You might know the team I'm lucky enough to be a part of as the MyIG Source Patient Advocates. I know that throughout my journey as a mom of 4 children living with primary immunodeficiency, the IDF has been simply an invaluable resource to me. I hope you learn a ton, and if you need us, know that nobody should ever have to do this alone.
Hi, my name is Ricky Ment, and I'm one of Grifols' IG nurse educators. I'd like to talk about Grifols' resources for people on IG treatment with either Gaming XC 10% or Xembify 20% subcutaneous. Both products are for the treatment of PIDD and offer copay assistance of $10,000 per year for those that qualify. For those without insurance, please visit gamingxc.com or Xembify.com for more information about Grifols' patient assistance program. Both websites have infusion videos to answer common questions, informational brochures, and links to organizations for educational resources. Thank you to everyone listening tonight, and thank you to the IDF for having us.
So thank you. Thank you to CSL Behring, Grifols, and Takeda for your support. And we will be hearing from a couple other sponsors after tonight's presentation. So at this time, I am honored to introduce our presenter, Dr. Javier Chinen. Dr. Chinen is a specialist in allergic disorders and immunology defects. He has an extensive clinical experience acquired during his work at centers of excellence, such as the National Institutes of Health, Downstate University of New York, and Baylor College of Medicine. Dr. Chinen has also completed graduate studies in immunology, which provide him with the basis for the understanding of allergic and immunological mechanisms of disease. Welcome, Dr. Chinen. Thank you for joining us tonight.
Yes, good evening. Thank you, Kathy, for your introduction. It's an honor to be here. Thank you for the IDF for the invitation to speak tonight. So it's always a challenge to give a talk to audience with a wide variety of interest. I try to have a good balance of simple slides and some a little bit more complex, and so I let the questions decide whether we need to be a little bit more in detail of what we are going to talk. So the topic is antibody deficiency, and what does it mean? Antibody deficiency is a term that might be used in different meanings from different people, different doctors. So I go to the basis. Let's see. This is not working there. So start with what are antibodies. So antibodies are part of the immune system, and I have a cartoon here representing the major function of the immune system, which is to resist the attack of pathogens as a shield. And then two other cartoons, one to illustrate that most of the antibodies are being distributed on our whole body through blood vessels. So we're going to find a lot of them in the blood vessels. And so here is illustrated by this structure that looks like a Y that goes around to all and travels through all parts of our organism. One of the things that I'm going to keep mentioning is the function of the antibody, which is to attach to a cell or a substance. And you're seeing here in the lower cartoon how the upper part of the Y is attaching, where is my pointer here? Is attaching to the cell, always this part in here. So other two cartoons on the side, on the right side, to see how we illustrate this Y, that's the shape of the antibodies. And even our National Institute of Allergy and Immunologic Diseases have decided to use the antibodies as a symbol of the major topic or focus of research. So that gives you the importance of the antibodies in the immune system. So there are 5 kinds of antibodies or classes of antibodies. The IgG is the one that almost all of us would be familiar with. Is the most significant for the defenses and for doing their action as an antibody. Then there is the immunoglobulin A or IgA, which is important in the mucosas, doing a similar job trying to fight the microbes that are outside us and get in contact with us in the respiratory tract, the gastrointestinal tract, and the genital tract. There is another antibody, immunoglobulin M, which is what we call first responders. This is important for the IgG to develop. It's not as significant as the IgG, but so highly important in order to develop the IgG. So by itself, it might be limited, but without it, IgG would not develop. There is another immunoglobulin, the immunoglobulin E, in very much smaller quantities. It's the one that people with allergies would be concerned about. It's something that when allergies are high, this antibody increases in the blood. And there is a fifth immunoglobulin, the IgD, which is accessory that we don't have a good idea whether it attaches to microorganisms and do a function. It's a very small quantity, but appears to be similarly to IgM, important in the development of the IgG, which is the one that is most fundamental or essential for our protection against microorganisms. Now, the IgG has 4 subclasses, and the only one thing that I would say about these 4 subclasses is that the IgG1 is the most significant for all the functions that we attribute to IgG. In second place, we would say the IgG2, and then there is IgG3 and IgG4, but those are not as abundant as the IgG1 and 2. So To summarize, there are 5 classes of antibodies. The IgG is the one that we focus on, and from the different classes of IgG, IgG1 and IgG2. So what does antibodies or immunoglobulins do? Many different functions. So in this cartoon, I put as a representation either a tumor cell or an infectious agent. So antibodies would mediate the destruction of these elements that can produce disease. They can attach and produce direct effects by altering intracellular signaling, inhibiting any function of the cell or the infection, or inhibiting the invasion of the microorganism in the body by altering their adhesion to surfaces. So in this cartoon, the antigen is the target of the antibody. Remember the Y that attaches in there, and it can produce a disturbance on the cell or the infectious agents. Another way is that it mediates the recognition of these, let's say, microorganism by macrophages. So these are cells of the immune system that when they recognize that there is an immunoglobulin attached, they know that that is something that they would like to eliminate. And so they will attach to it and they'll try to destroy this structure. I mean, the size of this is not up to proportion, but one of the things that the macrophage do is endocytose eats the whole thing inside and destroys it. Another way in which our immune system uses the antibodies is by these natural killer cells, and these little spheres or circles represent molecules that, when attached to the cell, it will produce holes and destroy this organism. And one last thing is it mediates the recognition of another part of the immune system called the complement that also produces little holes that destroys this microbe or pathogen. So all of these different functions makes the immunoglobulin very essential in the defense against microbes, but also against tumor cells, and results in the cell death and the elimination of these elements that produce disease. So when we talk about antibody deficiency, there are 2 things that we need to keep in mind. One is that we don't have enough quantity, that there are too little, and another in which we have enough, or at least it looks like we have enough, but these antibodies don't work. They are of bad quality. So quantity and quality. So when we talk about quantity, we need to remember that it's not the same throughout life. Adults, children, and infants have different levels of antibodies in their blood. So when a baby is born, he or she is born with antibodies that have been transferred from the mother through the placenta at very high levels. And this is represented by the red line. So it's very high at birth. This maternal antibody starts decreasing in concentration as time goes, and there is very little by 4 to 6 months. As the baby is born and gets in contact with different antigens from the environment, the baby starts producing its own antibodies. And so it starts from 0 all the way to adult level. So it reaches an equilibrium with the adult level almost after a year or 2. This is variable, and so it's not exactly at a particular age. We say that by age 5, the antibodies should be at regular levels. So the total IgE is going to be the addition of what is in the blood from maternal source, from what the baby is producing, and is lowest in between 3 to 4 to 5 months of age. And that is a time in which we believe that the babies start gaining their own strength in terms of producing antibodies. Okay. So insisting on first, we need to think about quantity, and that if we have low concentration of antibodies, low amount of antibodies, it might be that the body is not producing enough, but also we need to consider that we may be losing antibodies. And so I put a cartoon of a jar to illustrate how this happens. Either we are not producing enough, or we are losing through places. And this is more common in adults, in which they might have secondary conditions in which they lose protein, and particularly antibodies. So the sources to look for losses are in the urine, usually kidney disease, but also people who have loose stool might lose protein and antibodies, immunoglobulins to the stools, and that produces a lowering of the concentration in the blood. So in these states, it's not that the body cannot produce, it's more that it's losing too much. And it's not as bad because the body can still mount the defense that is needed for new organisms or new bacteria or new viruses. It's just that it doesn't stay for long because are more than the production. So to repeat here, excessive losses, stools, diarrhea, kidney problems, something that we call proteinuria. And there are other situations in which the protein gets lost, like people with severe edema. We have liquid in our tissues, and with that also goes protein and immunoglobulins or antibodies. Usually we get mild or temporary decrease of antibody levels that are associated with the activity of the primary disease. And so we expect that once we resolve this part, then we get the quantity of our antibodies got to level. Now, there is another part, which is the quality of the antibodies. We might have normal levels, however, these antibodies don't work well. So this cartoon shows how we understand the antibody response or the immune response. So every time that we get in contact with a new antigen, a new substance, and that is substance A or antigen A, we get a response within 2 to 4 weeks, and it's a small response that might or might not be enough to protect the body against disease. It's only when we get a second exposure that we get an exponentially higher amount of antibodies. And this is the basis why we have vaccines and vaccines boosters. So with the first response, we are going to have kind of what we call a priming. And then when the real infection occurs, we'll have enough antibodies that will stop the infection to get into severe illness or disease. This response is specific for a particular substance. That means that if we get exposed to a different substance or protein or antigen, then we get again a small response. And that is also nowadays, and if the COVID epidemics has brought anything positive for the immunologists, people have a better understanding of the role and the value of the antibody responses. And so this would be what happens and how do we explain that people still get infected with COVID is because as they change, then you're having a different antigen, and that's the examples of the alpha, the delta, and the omicron. And we are concerned that the new variant is not going to be as good of a response as what we have already vaccinated on. Fortunately, we know that there is cross-reactivity, and therefore, in the case of COVID, this primary anti-response for one particular variant does also increase the response of the other variants, but not as much as if it was exactly the same one. This gets a little bit complicated, and for some of you that might be interested on why is that we might have antibodies, but they are not as good. Well, there is a whole process of molecules that interact with each other in order to produce an antibody that is good to fight a specific infection. And that has to do with all these proteins that are involved in the B cell that process proteins and antigens. They have to be what we call presented or interacting with the other arm of the immune system called the T cells. And there is a number of hormones, immune hormones called cytokines or interleukins, that after this interaction go back and tells the cell, the B cell, to produce these antibodies in a specific way. If we don't have good T cell help, we don't have these cytokines, then the production of these antibodies become very inefficient. This is another way to see that. So I presented the previous slide between the interaction of the B cells with the T cells. Here is further going into the maturation of the B cell to produce an effective immune response. So the one B cell that is specific for a particular protein needs to replicate, needs to further mature or differentiate into the plasma cell and produce these immunoglobulins or antibodies. And then again, the first is IgM, which is as a precursor, and it's important in order for the IgG to be produced. I mentioned the T help or the helper cells, but there is also the interaction needed with other parts of the immune system called the dendritic cells. There is a place in the lymph nodes called germinal centers in which this interaction occurs surprisingly in a very organized and directional way to produce the plasma cells and also to produce what we call memory B cells, which are responsible for this secondary burst of the production of antibodies. This goes into tissues, bone marrow, cells of the whole body, and being produced in one place ends up being a protection of the whole body. So again, Having an antibody deficient means either that the antibodies are low in their levels, but also that the antibodies might not work. And these things can come together. Either you have only poor amounts of antibodies, or you can have very low amounts, but then those antibodies do not work. So if a person has an antibody deficient and a doctor says, or any provider says antibody deficiency, that means that the person might have a higher risk of an increased frequency of infections than expected. We don't put a number because it all depends on the lifestyle of each individual. It's very common to hear, oh, it's in daycare, so he has many infections, but this doesn't mean that that happens all the time. It depends on the daycare, it depends on the kid, and it depends how often you take the kid to the daycare. So all of these are variables. In average, as a pediatrician, I would estimate that a kid should have an average of no more than 6 respiratory infections per year. But that is a number that we need to consider with several variables, as I previously stated. Not having good antibodies also means that the infections might be more severe, meaning that a bacteria might produce a sore throat in an immunocompetent patient, in a normal person. But if you don't have antibodies, that bacteria that produce a sore throat will produce a pneumonia, because the antibodies help the person to stop the invasion of the bacteria through the body. Also, prolonged time to recovery. So it's common to say, oh, the antibiotics cure the infection, but really the antibiotics don't work by themselves. It's the immune system actually getting rid of the infectious organism, and you have antibiotics or antivirus to help the immune system control these infections. Now, I do mention other immune problems, inflammation, because many of our patients with antibody deficiency also have an excess of inflammatory phenomena, meaning that the other cells trying to compensate for not being regulated well have more swelling, fever, more than individual normal antibodies. So these infections, what are those? So this illustration to focus on what do we see as soon as we know that the patient is having a decrease on the concentration of antibodies in their blood. One that is common is pneumonia. So pneumonias can occur in any normal patient. It's just that, again, it's more frequent than the normal, or it's hard to treat, or it's more severe than expected. Sinusitis is one that is very challenging, because a lot of people have sinusitis just based on the fact that on risk factor, which is allergy inflammation. But if allergy inflammation is controlled and we still have too many sinusitis or too severe, then it's worth antibody responses. Similar to sinusitis, the ears, then the gastrointestinal tract in the form of loose stools or diarrhea. So what these things have in common is that this is mucosal, is where organisms get inside the body, and it's the first line of infections. So especially in children, it's something that we see as a genetic condition. And so I named here a few of the names of conditions that are said is an antibody deficiency. For adults, this common variable immunodeficiency is a diagnosis that is the most prevalent in adults. Is that the antibodies start to decrease in amount in the peripheral blood. Another condition that is very common is transient hypoglycemia of infancy. So if we recall one of the slides in which I show how the baby is producing antibodies and the maternal ones are coming down, sometimes that very highly regulated balance doesn't work as well. And the babies have a low antibody level in the blood. And we call it transient because if we wait enough time, the child gets to a normal value. And it's something that we see only after we wait enough time. But that doesn't mean that the baby is normal, because if they have critical low levels, they are similarly susceptible to have severe infections. The X-linked gammaglobulinemia is one of the very first immunodeficiencies that were reported genetically. It's mostly presented in males. And basically, you don't have B cells, which are the ones that produce the antibodies. There are these two that I put it in here, selective IgA deficiency and selective IgG2 deficiency, because oftentimes we find that these are the only anomalies in the blood when we measure, and this is the subclass that I was mentioning earlier. However, there are many patients that are normal without infections that have this diagnosis. So we need to really evaluate the person, the patient, and have the history of infections before we do an intervention, because these two diagnoses might or might not be significant on the immune system of a particular individual. And I highlighted the T-cell immunodeficiencies in the sense to remind us that there is an interaction between B and T cells, and the separation is not clear. There is effective communication, and every time that we have T cell problems, we are going to have B cell problems. Secondary causes, I just put it in bold, because most of the time it's not primary, it's secondary, it's due to other things, as I said, kidney disease, loose stools, diarrhea. Some medications can cause a decrease of the immunoglobulins. There is also other conditions, some cancers and some rheumatological conditions that come together with a decrease of antibodies or immunoglobulins. So it's not straightforward, and every time that we say antibody deficiency, we want to really go a little bit deeper and try to find out the exact diagnosis. So once we have immunoglobulin deficiency or antibody deficiency, what are the basic things that we need to do? So what does that mean for the patient? I separated in three important items. The first thing is we want to prevent infections. We want to do what we find we can do to prevent infections, even if we have replacement, which is the second part of it. We need to seek that we replace the immunoglobulin levels that we are not producing. And the third thing that has come to light in the last couple of decades is that many of these conditions is not just about infections, but then there are what we call non-infectious complications. And these are in the example of enlarged lymph nodes or enlarged spleen. Prevent infections is to reduce the risk with good hand washing, avoiding crowds, because most of these infections are from person to person rather than coming from dirt. But always try to use boil and bottled water and everything to be as clean as can be. IgG replacement, nowadays there are two ways of doing it, intravenous and subcutaneously, and so those are cartoons to show. And the third is the non-infectious complications, and there are plenty of those. Chronic lung disease, granuloma, joint pain, autoimmune conditions, anemias, and thrombocytopenias. So it's important that once we start the management, don't just keep receiving the IgG without periodic visits with the clinical immunologist to find out whether something non-infectious or infections that might be subclinical, that may be not manifested, could be going on. So in summary, what does antibody deficiency mean? It means low IgG levels are suboptimal antibody responses, an increase in the number of severity of infections, or the risk, because if we are well managed, we should not be having this risk of infections. The need of measures, so we cannot just go ignoring it. And knowing the fact that if we do have IgG supplementation, there is nowadays life expectancy that is quite similar to normal population.
Hello, my name is Brian Hartline, and I'm a Senior Medical Director at Farming Healthcare. We are a biopharmaceutical research organization focused on transforming the lives of those living with rare diseases by providing novel treatment options. APDS is a rare hereditary primary immunodeficiency disease impacting the development and function of immune cells. APDS presents with a variety of clinical features, making it difficult to diagnose without a genetic test. To learn more about APDS or sponsor genetic testing, please visit allaboutapds.com. Thank you, IDF, for all you do for the PI community. It's been Farming's pleasure to partner with you. Thank you.
So let's get started. What can one do to boost the capacity to produce antibodies, prevent infections, besides infusion therapy?
Well, it's about good nutrition. The problem when the body does not produce enough antibodies is either we don't have enough B cells, which are the factories that produce the antibodies, or those B cells don't work. And when that happens, there is not like a food or an external thing that makes the B cell to either be more or be stronger. It's basically a B cell, the factory has all the nutrients that the body produces. And what I can advise is a good quality of life and good nutrition in general, which I would say somebody who's concerned about this should already be doing. Anything that affects the body in general in terms of malnutrition, toxics, and chemicals affects all the cells of the body, and the B cells is one of them. There's not a particular element that affects only the immune system and not the rest of the body.
Okay.
Yeah.
Is there a cure for CVID?
Well, as we learn more about CVID, it becomes more apparent. This is a primary condition, meaning that it's genetically determined. There is a number of genes, up to 18 and more to come, that explains about 20 to 30% of the CVID cases. The rest, we don't have a one explanation, and it's likely that it's going to be what we call a multigenic, several little defects coming together. So some people have proposed to change the whole B cell system or hematological system, but the risk of doing a bone marrow transplant, which is what it means, it really doesn't justify doing it.
Yep. Antibody deficiencies and being hereditary. What
Right.
is the percentage?
It's hard to tell because there are too many different genes now that produce antibody deficiencies. And there are some of them that we call it dominant, meaning that it only takes one parent to have the gene problem, to have the children the same problem. But most of these genetic problems, we need to have an error in both the mother and the father in order for the kid to have a problem. An exception is what we call X-linked diseases, in which if the mother has the error and she has a boy, the boy is likely to have it. So I don't think I'm able to explain the complexity of the genetics on this. Right. But it's very important that anyone who has an antibody deficiency explores the genetics of it. Want to see whether we can identify the gene, and that gene has a particular way of behaving and can predict what you might encounter in the future. And second is if the family has any other relatives, and we do find a gene, you can alert, provided everybody agrees, other members of the family that they might or might not be having a similar problem.
Okay. Can CVID be present from birth, but undiagnosed until someone is in their 20s?
Correct. So this is a yes and no. The CVID is at least the forms that we kind of are convinced that have a genetic etiology. We understand that there is a problem that is in the genetic code, so that you're born with it. But it takes years to get clinically evident. So the gene problem is in there, but the CVID itself is not. And so, because it takes years to develop, we talk about two peaks, one in adolescence and one in their 30s and 40 years, in which the CVID gets manifested. So the answer is, yeah, the problem was there, but I wouldn't say undiagnosed, because there is no reason to be exploring a baby that is healthy.
Does being deficient mean higher chances of autoimmune issues down the road?
Okay, that's a very important question because I did say that. I said about the non-infections problems, and autoimmunity is one of those problems. So as we've been following more and more patients, we realize that there are a few subgroups in CVID. Some of them, the only thing that they have is antibody problems. But there are another group in what, and they do develop increase of what we call autoimmune or dysregulatory problems. And this has to do with the fact that CVID is not one condition, it's a group of conditions that we are trying to solve, but we can solve only, as I said, 20 to 30% in terms of genes. And the answer is yes for a subgroup of CVID patients. And we don't know unless we get the gene defect or we follow for enough time. And if within 20 years, we don't see any of these dysregulatory problems or autoimmunity, we can say, well, the likelihood of this happening is not there.
I am on Rituxan to manage an autoimmune disease which depletes B cells. Does that mean I need to get IG replacement?
So up to a few years ago, rheumatologists and oncologists that need to deplete or target B cells would not really check this. And the rationale was that the body produces B cells, and medication to target B cells only target the mature ones. And so as we target the mature ones, the body, after 3 to 6 months, starts producing more B cells, and those B cells eventually will get into immunoglobulin producing cells. So it was thought that this was something that we can do and target the B cells, and then after that, it's going to be okay, the patient will get back. But after about 20 years of using this thing, we know that, again, a subgroup of patients that are susceptible for this, you deplete the B cells and they don't come back. So whether we need or need immunoglobulin supplementation depends on how the treatment is affecting a particular patient. How do we do that? By measuring the antibodies. So we wanna be sure that before the depletion, we have good levels of antibodies, and this is not somebody who, before the treatment, already had low antibodies. So then we give the treatment, and then we monitor from time to time whether the immunoglobulins are at the normal level. It's often the case that if you use only 1 or 2 depletion treatments, the immunoglobulins do not have any kind of depletion. And that has to do with the research of the body on the antibodies. It takes a long time to deplete them. But the more treatments, the more likely that a patient will need supplementation.
Thank you. Is there a difference between people who have a primary immunodeficiency and those that take medication that makes them immune deficient? So are their futures the same outlook, but even though they come from different backgrounds, or are they very different?
Right. So this is the question about primary immunodeficiency or one for secondary causes, right? So when there is a secondary reason, somebody is giving you a treatment, then the issue is for how long is this treatment? As I said on the previous answer, the one guide whether one needs to be treated or at least be aware that infections can happen is the level of immunoglobulins. If the treatment to deplete the B cells is short, then we can take be patient and see and wait. But as we need a prolonged treatment, then inevitably the immunoglobulins are going to go low. And once it takes a critical level, then in order to be safe, we want to replace. That critical level changes on who's the expert managing it. Some people say 400, other people say 300, other people say 200. A lot has to do with the condition of the patient. You don't want to add additional treatments. It has to do with how careful or not careful, how the environment of the patient is. It's not the same if somebody is constantly exposed to children versus somebody who lives isolated. So then there is not a single response for each one, but the one thing that is in common to one that is primary or congenital versus the secondary or somebody who's getting a treatment is the level of immunoglobulins. That should be the guide on whether we need additional treatment in order to decrease the risk of severe or unusual infections.
Okay. Talking about specific antibody deficiency. If a child is diagnosed at the age of 5 or 6, what is the likelihood of outgrowing that deficiency? And what kind of protocol is there for surveillance, for complications and everything moving forward as they grow older?
So that is a question that is very important in pediatrics. And the key point in there is that when we deal with a 5-year-old, one of the things that we need to take into consideration is the maturation of the immune system, and with that, the levels. And by far, we believe that by age 5, we should be with regular, normal range of immunoglobulins. So once you get the diagnosis of deficiency, you got the 5 years in there, chances are that that is going to be for life. If there is a primary factor, something that produces this depletion or decrease of antibodies, or whether there's something that is functional, like a medication or another disease, another treatment, then you have a chance that that's going to go better. A lot has to do also with which level was used to determine that it's an antibody deficiency. If we get 0 at 5 years of age of a level of antibodies, for me, that's congenital. It's not going to get better. If it is like 300, 400, I would say, well, you probably are outside that, you're in the normal, but outside the limits of normal. You have that chance, be optimistic, we'll do some supplementation, but we'll keep monitoring. And I have had patients that I have diagnosed as antibody deficiency, excuse me. And then I started with a supplementation, and suddenly I see that with the same dose, the baseline starts increasing. And those are the patients that eventually I take away the supplementation and they are good.
Yes. Along that line, how is specific antibody deficiency different from the other antibody disorders?
Well, so the specific antibody deficiencies are more into whether you can respond to particular antigens. And the most common one is the pneumococcal one. So when we say a specific antibody deficiency, we assume that the levels are normal, but it's not working right. Sometimes it just needs another booster of the vaccine, and that proves you that the body can do it. Just needed an extra stimulus, an additional stimulus. Sometimes it's a question of maturation. From all the conditions in which we find genetic problems, in the specific ones, is one that is so far we don't have a genetic cause for that. So some of the thoughts are that this is probably something that has to do with maturation.
So we're going to move on to IgA deficiency. I have multiple questions regarding IgA deficiency.
Yeah.
Let's start with the first one. How is it diagnosed?
So IgA deficiency, that is one of the classes of antibodies. It comes right second to IgG in terms of importance. But the way to diagnose is because it takes even longer for the IgA to mature than the IgG. This 5-year limit has to be set. So there could not be anybody who said it's a IgA deficiency if it is under 5. We say IgA deficiency, anybody whose values are outside range, usually is under 6. 20 years ago was under 10. So it has to do with how little we detect that. And it's basically a laboratory diagnosis. We measure in the blood, it's low, you are over 5, it's low, then you get the diagnosis. The complexity of this is that the laboratory value does not always correlate with disease. So we know from surveys in blood banks that there are many healthy individuals who do not have IgA. But then we know that there are patients that are sick, that the only abnormality that we find is that they don't have IgA. So it becomes a clinical question, whether the laboratory matches what we see in the patient. But the diagnosis is basically a laboratory value, whether you have it or not. So, but everybody should be cautious that having an absent IgA does not mean 100% that there is going to be a problem.
And then how is it treated? Can you get immunoglobulins,
Right.
or is there something else?
So no, there is no currently a proven IgA supplementation similar to IgG. What we know from studies in experimental animals and also in biopsies of the respiratory tract is that the IgG goes to the mucosa and supplements what the IgA was supposed to do. And so in people who don't have IgG, who don't have IgA, who don't have any IgM, who don't have any of the IgG immunoglobulins, the IgG by itself reduces the risk of infections to normal or close to normal. So based on the years of experience with IgG supplementation, there has been little effort on trying to replace the IgA. There are going to be a small group of patients, I would estimate less than 1%, in which it appears that this mechanism of IgG going into the mucosa is not as efficient. There are many things that make the blood, something that circulates on the blood, go into the respiratory tract. And so if you have selective IgA deficiency and have infections, the first thing is to know whether there are other problems in other immunoglobulins, particularly IgG2. There is a connection between IgG2 and IgA in the way that the genes express these proteins. So if it is absolutely IgA deficiency and there are infections, that the only possibility is this deficiency, then the management at this time is using antibiotic prophylaxis. There's going to be over there, some people are offering cow's milk and baby's milk, but there's plenty of that, but nothing proven that does the job, or nothing that we can say is effective, at least in an acceptable number of patients.
If you have a child that's going to have an adenoidectomy, or even an adult who has low IgA, is that a safe procedure to have if they have an antibody deficiency?
So for IgA deficiency, in general, it is a relatively safe procedure. Surgery is surgery. I'm not a surgeon, so there's always risk.
Yeah.
Years and years of experience have shown that there is not a clear risk that of infections or anything that is related to having an IgG deficiency for an adenectomy.
Thank you.
In reality, it's actually helpful because a lot of patients, deficient or not, have an extra enlargement of the adenoids, especially when they are below 4 years of age, younger than 4 years of age, in which the management of secretions produces a lot of infections, and then by removing these masses, the secretions are drained well, and then your overall number of infections get reduced.
I have some IgM questions. So how does IgM deficiency affect our health? And what does it mean when the level drops significantly within 6 months of someone who has CVID?
Yeah, so that tells you, so CVID is very different in the sense that it looks normal for a long time, and then suddenly it starts producing problems. The theory, and that is something that is not being well explained, because nobody does an experiment on 40 years of people, is that it appears that the memory capacity of the B cells starts not to hold it anymore. As you don't have memory, then the B cells start disappearing. And when I said that the IgM is the important precursor of IgG, it's the very first thing that happens from B cells. And so without counting the number of B cells, the IgM is the closest marker for how many B cells you have in your body. So if the IgM is dropping in 6 months, I expect that the B cells are also dropping in amount. You are in mute.
Sorry. You said mostly males for X-linked A gamma globulinemia. However, I have always presented as X-linked, but I am female. Are there females with this diagnosis?
Yes, yes. And those are very unique individuals. X-linked means that it's in the X chromosome. Women have 2 X's. Males have an X and a Y. So if anything goes wrong in the X chromosome, that is the only chance, and that is what happens on X-linked gamma globulinemia. However, in females, you have 2 X's, and that normal X usually is enough to supplement the wrong one. But there is a possibility that there are errors in the 2 copies of the X chromosome. There is a possibility that the only one that is working in the X chromosome is the wrong one. And there are some changes genetically in which they call it X inactivation, in which these very unusual events happen. So a female with a diagnosis of X-linked gamma globulinemia is likely to have a very unique genetic conformation of these genes.
Thank you. How are memory B cells involved with antibody deficiency? Do they build up a response and then lose it?
Right. So the memory B cells are cells that are kind of guarding it, and when they get stimulated, they start producing antibodies or being differentiated into producing antibodies. So in CVID, we believe that that's likely the thing that kind of unifies what we observe in the patients, that the memory B cells stop being produced or activated, and they start dying or not being able to continue replicating. So the memory B cell is one that has encountered an antigen or a protein in the past, and because it's primed, has already know it, has a capacity to very quickly reproduce and produce, differentiate and produce lots of antibodies. So when this cell is no longer there or is dying for a possible problem in the cell mechanism, then that is what CVID appears to debut or start manifesting with a low immunoglobulin levels. But it's not just a memory cell, so there is that is only a subgroup of patients. There is another cell that is as important called plasma cells, which is the next step of the B cell. And so the plasma cells are very similar. They need to be activated in order to produce lots of antibodies. And so either the memory B cells or the plasma cells, when there is something wrong in their reactivation, then you start seeing a decrease of the antibodies, and you see that there is a disappearance of these important cells for the production of antibodies. But for what is puzzling all of us is, why does it take 30 to 40 years for this to happen? And the thing is that it looks like our immune system has some sort of a time clock. There are things about how many times the cell can divide, how many times your skin can divide, and all those things are not well understood, but we know that that is a phenomenon that is likely to play a role. How much one particular part of your body can replicate over and over and over in order to keep the immune response going in forever.
So let's talk a little bit about vaccines. There's a couple of questions. What's the rationale for getting killed vaccines if a person does not make antibodies? And then is there timing with infusion therapy and getting a vaccine?
Yes. So it used to be a dogma that people who receive immunoglobulins, they don't need to get antibodies, or there is no use for it. That started to get challenged. First, because there are too many different types of antibody deficiencies. And none of and probably the only absolute one is the gamma globulinemia, either the X-link or the other forms. All the others, there is some sort of a residual function. And so the vaccines, and then we're talking about inactivated, not anything live or attenuated, but the proteins and the foreign antigens. So there could be a residual function that nobody can measure other than you put the vaccine in there and see what capacity the patient has left to produce an antibody. And that has been shown in COVID in some patients. So it is not, so we will have to do a research project in every single case, but basically it's about what residual capacity the patient has in order to produce an antibody response. Those who have the X-link have zero antibody level. That's probably in them, we are not expecting them to produce any. But if you have like 50 or 100, then there is a chance. There is no sure thing, but there's a chance. But then there is the other component that has kind of been forgotten when we see this patient is the T cell part. So T cell can still respond, and it's probably very significant on these B cell deficiencies to keep the patient relatively free of infections. So you might not produce antibodies, but then you have the T cell part fighting or producing a response, cellular kind, but produces a response to these foreign antigens or proteins. And again, this has been shown. The problem is that we cannot generalize to everybody. There's going to be some groups, yes, and not every patient will benefit. But there is not a contraindication to give an inactivated vaccine to people with immunodeficiency, other than they would have to get another injection.
Could you explain more about 22q11 deletion? There are T and B cell deficiencies and also autoimmune 200 times higher incidence of ITP.
Okay, so the 22q11 deletion, that is a genetic condition that has a name called the George syndrome. It's a pure T cell deficiency. I mean, it has other problems, heart problems, endocrine problems. In the immune system, it's a pure T cell problem. And there is a whole wide range of people who have 0 T cells and people who have 100% T cells. The B cell part of the DGeorge syndrome depends on how good are the T cells. If the T cells are normal or near normal, then there should be no B cell problems. If the T cells are closer to low or 0, then you have an abundance of B cell problems because there is not enough T cells to help the B cells to produce the antibodies. B cells cannot produce significant or efficient antibodies without T cells. So the T cells are fundamental. And I did have in my slide a kind of remarking this concept. The autoimmunity comes in the fact that if the T cells are not enough to produce an efficient and effective B cell help, the B cells go a little bit crazy. And so these T cells make the B cells produce antibodies they shouldn't be producing. And that is what autoimmune cytopenias are going to start showing up. The autoimmune cytopenia basically means that the B cell is not well regulated. There is not enough regulation of which antibodies need to be produced at a particular time.
Is there a relationship between Epstein-Barr virus and immune or antibody deficiencies?
That is not an easy question to answer, but the answer is that there is a relationship. Yes, there is a relationship. Epstein-Barr virus prefers to get inside B cells. And once it gets inside B cells, it can produce a number of things. One of the things is cancer. So if you have Epstein-Barr virus, you have predisposition with multiple gene combinations, then one of the things is you get what we call lymphomas, a big lymph nodes. You can see it all inside. But then you might get the Epstein-Barr producing the B cell to be there and do nothing. And that is when you get a B cell deficiency. We don't know who is going to develop what. 99% of the patients get Epstein-Barr virus. You get a good immune response to it. You eliminate the virus, end of the story. So Epstein-Barr is the one that produces the mono, usually in teenagers. But a lot of kids also have it. And so there's going to be the one patient that might have a B cell dysfunction. And in those cases, we want to see what else is happening with that patient in terms of other gene defects, or also whether the T cell function, the NK cell function, or other parts of the immune system that we need to get rid of this virus are not in place.
What IgG level counts as low, and at what point should treatment be started?
Yeah, so there is a different numbers for different specialists. I would say that most common here is 400 milligrams per deciliter. Some people say higher, some people say low. The normal is 800 to 1,000. For decades, we thought that 400 was the minimum, and so I would say the majority of experts consider that the level. But it's important to don't just have one value. These changes, there are different reasons why this value can go lower or can go higher. And I would say it's not an easy answer. You want to have a specialist going into those values before you decide that the immunoglobulin replacement is needed.
Thank you. We're going to end with a question that we get quite often, and it was asked again this evening. For those who are antibody deficient, how does cancer treatment, whether it's immunotherapy, radiation, chemotherapy, how did they respond with having also have, that's a lot of haves, they have an immune disorder, it's getting late. But how do they respond with the chemo treatments and the cancer treatments? And do they continue their IG replacement while they're getting their treatments?
Right. So the question is all about details. There are treatments and treatment. There's chemotherapy and chemotherapy. But somebody with antibody deficiency, and if that is the only issue, there are no other immune defects, the immunoglobulin replacement restores the normal or risk of infections. When we give immunotherapy, cancer therapy, chemotherapy, that affects cells. That doesn't affect the protein that is in the blood. So if we have some B cells producing very little or some immunoglobulins, it might deplete it and totally eliminate those. And what you would see is some of a decrease of the immune globulin levels. So you would adjust the doses and probably increase to the level that you want to keep. But that is probably the only consideration to do when somebody who already is receiving immunoglobulins needs to receive immunotherapy. Cancer therapy or chemotherapy.
Dr. Chinen, I totally echo Colleen's thank yous and compliments. And actually, we have a very lovely message that we have received in the chat for you from Lynn, the wife of our wonderful late Dr. William Scherer, who we so fondly remember and was such a leader in this community. And we know that you trained with Dr. Scherer prior to heading off to NIH, and look at you now, back where you started and where, he was a leader and you are a leader, and she says, so proud of you. So Thank you. Cannot thank you enough for being here tonight and for all the information you provided to us and the care you provide to individuals with PI and the wonderful research that you carry on from your mentor, Dr. William Scherer. Thank you.
All right. Okay, well, thank you for kind words. Yeah, Dr. Scherer, my mentor, and we'll try to continue all the great work he's done and continue his legacy.
Thank you. And
All right.
with a final thank you to our featured sponsors tonight, CSL Behring, Grifols, Takeda, Adma Biologics, Farming Healthcare. Thank you for sharing information with us tonight. And as always, thank you to each and every single one of you who joined us tonight, submitted questions before the forum, during the forum. IDF is here for you, and thank you. Take care.